Thanks, Dr. Anaga, for the opportunity. And of course, it's very difficult to contradict the statements made by the kings and pioneers in SICS and Phaco emulsification. So I just want to prove my point of FLACS for brown cataract. We all know, the cataract cases like this, brown to black cataract or a brown cataract. It's a nightmare for many of the phaco surgeons, especially the budding phaco surgeons, for obvious reasons. This is what you can expect in many of the cases if it is not done properly, if you have not taken proper precautions. And don't be a fool, use proper tool. If you have a tool, definitely you try to use it. And quality is everyone's responsibility. We have to give good quality to the patient. So if the patient can afford, definitely you have to give a good quality surgery. And if you see here, this is a brown cataract. You can see a nice rexis being done by the femto. And nice segmentation has happened, and it's just you just have to separate these segments and just emulsify it. It's easy. Its life is easy, and if the patient can afford, definitely you can give this particular benefit to the patient. And you just have to identify the cleavage line of the femto laser and impale your phaco tip. And just with the help of a second instrument, you just have to separate it. It's just a lateral separation you are doing. So you are saving so much on the phaco energy. Here, for this particular step, you have used only two. This is the CD. And you just emulsify each segments one by one. And at the end of it, the surgery is over. It's just 10 is the CD here. You would have used 30, 35 if you have gone ahead with the phaco emulsification without femto laser. So at the end of it, you see a crystal clear cornea. The wound is so clear here. There is no wound burns as such. So this is what is needed for a patient. There are various publications on this. Fully tailored fragmentation is possible, adjustable grid size, energy pulse, and horizontal and vertical spot spacing can be done depending on the different grading of the cataract. And FLACS system allows for a dense grid pattern which can further reduce the effective phaco time, which can reduce 86% of your phaco time. And high quality fragmentation has significant benefits in very dense cataracts like this, what I have shown here. So it has made life easy. If you have the facility, definitely you can use it. Jagannath Boramani sir is a pioneer in SICS. He has taken out a nucleus, such a large brown to black cataract. But of course, like I don't say that it is his surgery, but it can be expected, and you can see the cornea on day one. The king of phaco emulsification, one of the best phaco surgeon internationally, Dr. Suhas. I have a lot of regards for sir. But it can happen to him. This is the first day post-operative picture. There is hardly any endothelial cells. So, but FLACS is the best, the preoperative, the nice glistening specular microscopic count of around 2,700 cells. Post-operatively, day one, you have a crystal clear cornea, and cell count is just 10% less than the preoperative level. So, I just want to conclude my talk. Technology is closing the gap between what one can imagine and one can do. So if you have the technology, use it to complement your technique to give the best to your patients. Thank you very much.
Thank you so much, Dr. Shreesh Kumar. That was very well said. Okay, so coming to the point, agreed that each case is going to be different. Now let us divide it into two parts. So there are two basic critical parts. First is the capsular access and second is the nucleus management. So I would like to ask Dr. Anurag Mishra and Dr. V.C. Mehta sir. Dr. Anurag, considering it was a patient who was an 85-year-old patient with a dense brown cataract, assuming you have access to all the technologies and cost is not an issue, what would be your procedure of choice? Now I'm speaking in terms of the capsulotomy, and I would ask Dr. V.C. Mehta sir in terms of nucleus management.
See, FLACS for me is a technocrat's fun. It's a lot of fun to work with that machine. I enjoy more than even the CCC and the nucleotomy. I enjoy making corneal incisions with that. I make all my ICL incisions, which are 3 millimeters, and they give me an SI of around 0.1, which is fantastic. Since you mentioned the age of the patient, 85 years, I would definitely look at the endothelial status, because mind you, when we're using phaco energy, however large or big it may be in size, but we're using under the cover of viscoelastic. When we're using the FLACS energy, we are doing it without any cover of viscoelastic to protect the endothelium. So if you're going deep down producing this grid pattern, it is going to consume 1.9 millijoules, and staying in the eye for around 23 to 25 seconds, it's going to produce heat. So the endothelial status has to be looked at. For a brown cataract, asking me personally, I would do the corneal profile and the CCC, I mean the rexis. I would stay away from nucleotomy. I would leave the nucleotomy part to the phacoemulsification part, the phacoemulsification part of the procedure.
Sir. Sir, please come here. Sir.
I think the damaging part to the endothelium is the energy dissipated from the ultrasound. It's not from the femto, femto part. So you saw the case, only 10 EPT. I mean, that's unbelievable for a hard brown cataract. That's what you want. The maximum energy is spent in the phaco in taking out all the pieces, not in making all the pieces. It's the quadrant removal where it takes. And talking about the endothelium protection with the viscoelastic, when you are working on a hard brown cataract, you are working on a very high vacuum. So it's very quickly the viscoelastic comes up. So unless you top it up, in a brown cataract, I top it up at least 3 times in order to protect the endothelium. So if you look at the terms of the damaging factors, then the pre-treatment with the femto definitely reduces the amount of energy that you spend with an ultrasound in the eye, and that's very important.
Yeah, exactly. So in this case, what we are trying to say is, in a hard brown cataract, capsulotomy probably could be done either with manual or with the FLACS. But what is more important here is how you are reducing the energy by making the nuclear fragmentation and the choice that you get of nuclear softening also in many of our newer machines. Now, in these patients, also in the experience, Dr. Nagwekar, you have been using FLACS for a lot of time. Many times people say in such a hard brown cataract, does the femtosecond actually penetrate? Like for example, in white cataracts, it may not actually give us so much of an advantage. In hard brown cataracts, what has been your experience? Does it really make a difference, or does it not penetrate at all?
The penetration of the FLACS is dependent upon the opacification of the nucleus. So if you have a white cataract, there would be hardly any penetration. But if there is a brown cataract, and if the fundus can be visualized preoperatively, I mean, visualize means you can get a good glow. There is some transparency, however brown it is. That is the reason why on an optical biometer, you are able to get the actual length of the eye, even in a hard brown cataract.
Right.
So it being a light source, you have to depend upon the opacification of the capsule and the nucleus. So if it penetrates, it gives you. And once a plane of cleavage is created, all you need to do is get into that plane, and then the separation, as Dr. Shreesh showed, was very easy. So I don't think, and another thing, Anurag, maybe what you said is right, but remember that the capsule does not detach itself and float in the anterior chamber. So I don't know how much of energy is being transmitted to the endothelium because of the build of heat.
There are reports, and my experience also have seen that, and there is a non-resolving corneal edema, particularly incision or para-incision, and it stays for some time, particularly in those patients who have got low endothelial cell count. So that's the reason why it might not be damaging, but I just want to be on my watch, so any which way if the patient's going inside. But I agree with you completely. It gives us an excellent template. and the division and the fractionation of the nuclear fragments is excellent
Very
in
excellent.
brown cataracts. But Anaga, I think after the post-debate discussion has been all about FLACS v Phaco, does that mean that SICS emerges
No,
out
not
as
at
the
all.
clear
Actually, I
winner?
was about to come to it. So I think to sum up, the message that we need to give across is do what works well and what works best in your hands. There is no ego issue here regarding FLACS or Phaco or SICS. Finally, at the end of the day, we want to give good vision and a clear cornea on the next day to the patient. So on table, and each case is going to be different. No matter what we discuss here, on table, if you feel that there are some ligaments that are, zonules that are weak, or if you feel that the pupil is coming down, there are so many things that we may need to change. You may have done FLACS and then you need to convert to SICS also. There have been situations like that. So finally, at the end of the day, we have to do a good workup. Like he said, probably a specular is important in these, more important in these patients. A good counseling of the patient that you may need to convert also. And you need to be very proficient in your manual Phaco as well as in SICS. And if you have access, definitely why not FLACS? So, yes.
To the question that you asked about 85-year-old with the hardbound, sometimes you may be inclined to go for an SICS.
Absolutely. Absolutely.
that's
That was what I wanted.
That is what my point was. Since we were, after the post-debate discussion was FLACS v Phaco, does SICS emerge as the clear winner?
Absolutely.
So we are not debating it. We are not even debating.
Fine. So